Good afternoon, everyone. Welcome to the ASPPH hosted webinar on the latest supplemental issue of the journal Public Health Reports, the official journal of the Office of the U.S. Surgeon General and the U.S. Public Health Service. Thank you for taking time out of your busy schedules to join us for today's webinar. My name is Dr. Hazel Dean, and I am the Editor-in-Chief of Public Health Reports. I would like to welcome you to the webinar on behalf of the Public Health Reports team. Published since 1878, Public Health Reports is the oldest public health journal in the United States. Public Health Reports is dedicated to publishing original research, reviews, and commentaries in the areas of public health practice and methodology, public health law, ethical dimensions of public health practice, and teaching at schools and programs of public health. Before we begin, a few items of note. This session is being recorded and will be available on the ASPPH YouTube channel shortly after the conclusion of today's webinar. Please note that attendees may receive continuing education credits for certified in public health. You can ask questions or submit comments in writing at any time during the presentation by clicking on the Q&A button at the bottom of your screen. We will hold questions until the prepared content has been presented. Public Health Reports' most recent supplemental issue focuses on public health matters, insights from Tribal Epidemiology Centers. Today, we will hear directly from guest editors involved in the development of the supplement and authors who contributed to the supplement. They will provide firsthand examples of best practices and experiences that support culturally informed work in a tribal setting. They'll describe how data collection and analysis are community-based and meaningful to the people. Meaningful to the people the Tribal Epidemiology Centers serve, and illustrate the value of the direct relationships Tribal Epidemiology Centers have with other tribes, tribal organizations, and urban Indian organizations. It is now my honor to introduce our panelists for today's webinar. Kristen Mitchell-Box is a senior program manager at the Alaska Native Tribal Health Consortium, Alaska Native Epidemiology Center. She currently serves as the program director of the Tribal Epidemiology Center Public Health Infrastructure Program Network Coordinating Center, funded through a CDC cooperative agreement. Dr. Mitchell-Box will supplement and will lead our discussion. Megan Curry O'Connell is the Chief Public Health Officer for the Great Plains Tribal Leaders Health Board. The Great Plains Tribal Leaders Health Board represents 18 tribal communities throughout a 4-state region of Iowa, Nebraska, North Dakota, and South Dakota. The Great Plains Tribal Epidemiology Center is a core component of the Great Plains Tribal Leaders Health Board, providing leadership, technical assistance, support, and advocacy for the tribal communities throughout the region. Dr. O'Connell received her undergraduate degree at Grinnell College and her medical and public health training at the University of Washington. After completing residency in family medicine at North Colorado Family Medicine Residency, Dr. O'Connell practiced primary care, including full-scope family medicine in tribal and underserved communities. Ashley Hoover currently serves as the Sexually Transmitted Infections, HIV, Hepatitis C, Epi, and Clinical Support Manager with the Northwest Portland Area Indian Health Board, and has been at the board for nearly 4 years. While at the board, she has worked on STI, HIV preparedness and response, as well as data analysis for a variety of projects. Ashley received her master's in public health from Tulane University School of Public Health and Tropical Medicine. and has worked in the field of HIV and STIs for nearly 9 years. Carolyn Parsall is an epidemiologist and the Student Development Director at the Albuquerque Area Southwest Tribal Epidemiology Center, also known as ASTEC. Since joining ASTEC in 2019, Carolyn has worked as project lead to oversample American Indian Alaska Native youth in the biennial administration of the New Mexico Youth Risk and Resiliency Survey. Since 2020, she has led COVID-19 response efforts in several tribal communities. And as the ASTEC Student Development Director, Carolyn coordinates student internship placements within the organization to support oversample American Indian Alaska Native students pursuing a career in public health. We will now proceed with the presentations from the authors of papers in the supplement, followed by a panel discussion with questions and answers. Please join me in welcoming our first author, Megan Curry O'Connell.
Good morning or afternoon, depending on where you are, and thank you for the introduction, Dr. Dean. I'm very honored to be here today to talk about our article that discusses access to public health data for tribal epidemiology centers. Next slide. I did not write this by myself. I wrote this with Charlie Abarask, who could not join us today. Neither of us have any conflicts of interest to report. And because this is a legal article, I should note I am not a lawyer, but Charlie is and an expert in tribal law. So I will do my best to represent what he has taught me and what we discussed in our article. Next slide. So our article was facilitating the urgent public health need to improve data sharing with tribal epidemiology centers. We decided to look into this issue during COVID, which I will talk more about in a second. And for a variety of reasons, we kept a very narrow focus. So this is not meant to be an exhaustive legal study of data access for tribes or anything about quality. There's a large range of issues surrounding tribal data access and quality issues and other issues related to public health data in tribal communities. This is really looking at the legal framework around tribal epidemiology center data access. Next slide. So as I mentioned, we started getting into this area more, both Charlie and I, during COVID, when tribes in our area and across the country really needed to get access to public health data so they knew what was going on, what were the rates of COVID, who had COVID, how they could provide services. And we learned very quickly it was very, very difficult. And we're looking specifically in this article at protected health information. So who, for example, has COVID or other diseases, so that those services can be provided. Although, of course, if you can access protected health information, you can access aggregate, or you should be able to access aggregate information as well. But we focus on PHI, protected health information, because that's the most specific. And again, if you can access that, you should be able to access other health information about groups of individuals. Next slide. Around the same time we were publishing this, should be one back, there was a GAO report that discussed tribal epidemiology center data access and noted that there were issues around tribal epidemiology centers being able to access data specifically within the Department of Health and Human Services, so HHS, which we'll talk about a little more. So this is really to say, don't take our word for it. We experienced issues, but this has also been noted in a number of other areas, including by the GAO in this report that came out in 2022. So this map shows a map of the United States and the different IHS areas, which many of you may be familiar with on this call. But each area has a tribal epidemiology center that was created by Congress to serve them and support the tribes in the area to perform public health functions, and that can be done in a variety of ways, from technical support or building up public health programs in tribal governments, or performing public health activities on our own. And again, as noted in the introduction, I'm the Chief Public Health Officer for the Great Plains Tribal Leaders Health Board, which houses the Great Plains Tribal Epidemiology Center, which is in the center of the country there, that kind of L of those 4 purple states. So what kind of laws govern public health data sharing for TECs? Next slide. The first is, of course, HIPAA. So whenever you're talking about health data, we are talking about HIPAA. So the Health Insurance Portability and Accountability Act really is often thought about how we can't share data, but it really should be considered about, it tells us all the ways that we can share data. So whether you work in a clinic and you're a covered entity, you can share data with your colleagues about a patient. In HIPAA, it also outlines that protected health information on individuals can be shared with public health authorities for public health purposes without patient consent. So it's another way that data can be used and shared to help keep people healthy. So when I'm doing it as a clinician, I'm working at that individual level, but HIPAA also allows data to be shared with specific entities called public health authorities to try to keep people healthy on the community level. And this is how data is shared routinely with public health authorities such as the state health department or the CDC. Next slide. So HIPAA was passed in 1996, and it laid out who public health authorities were. TECs were not included in that list at that time. TECs were just getting off the ground in the mid to late 90s. But in 2010, with the permanent reauthorization of the Indian Healthcare Improvement Amendments, TECs were declared public health authorities for the purposes of HIPAA. So TECs, or Tribal Epidemiology Centers, were added to that list of entities that PHI, protected health information, could be shared with. Great. That means TECs should be able to receive this information. Now, I mentioned that doesn't always happen, but the ability to receive it is there. Next slide. There's a unique statute around TECs, however, in that same law, the 2010 amendments to the Indian Healthcare Improvement Act, has this very unique statement, which is here, that not only allows TECs to receive protected health information like other public health authorities, but actually requires that they receive it for all data held within HHS, or the Department of Health and Human Services. So again, TECs have this very unique status where they're not only allowed to receive PHI, they actually are required to receive it. Or in other words, the HHS is required to give TECs the data that we need to perform our public health functions. And this, again, is not always fulfilled, but it is unique within the public health space. First of all, that there are TECs, which were created by Congress, that TECs are public health authorities, not directly listed in HIPAA, but added later on, and then that there is a federal mandate that TECs are to receive data held within HHS. And so we've tried to outline this kind of unique legal status for TECs and the ways in which they are not only allowed to receive data, but should be receiving data from federal agencies within HHS. Next slide. So again, to summarize, the federal statutes not only allow TECs to receive data, but also require TECs to have access to life-saving public health data held by HHS and its agencies. That promise has not been fulfilled, and we work very hard to make that happen. And we're hoping that this article helps lay out some of that legal framework for TECs to receive that data and improves access for TECs across the country. Thank you.
Thank you so much, Megan, for that wonderful presentation. And yeah, all the work that you do in the out there in the Great Plains. So hi, my name is Ashley Hoover, and I'll be presenting this morning or afternoon, wherever you're at, on the paper that my colleagues and I published as part of the supplement, and about healthcare access and lived experience of American Indian, Alaska Native, Two-Spirit, and LGBTQ plus participants in a survey that was conducted in 2020. So next slide, please. I have no disclosures to report. Next slide. And I'm not going to spend too much time on this, but I did want to just make sure that we're all on the same page of what we mean when we're talking about Indigenous people or Native people within the context of this presentation specifically, though could be expanded to others as well. But when in the context of this paper, a Native person or Indigenous people refer to the Indigenous people of the United States, and we include LGBTQ plus to refer as lesbian, gay, bisexual, trans, and queer, and questioning relatives, and any others that may fall within in between any of those designations. And then just a little note about Two-Spirit identity, that it's not necessarily about gender identity or sexuality within that Western mindset. So it's a recognition of the intersection between indigeneity and variance in gender identity and or sexual orientation. It's also a firm acknowledgement of one's self-identification with roles and ways of being that have been Indigenous in Indigenous communities beyond that Western binary through time immemorial. To give a little bit of background on why we decided to do this paper, thank you, I forgot to mention next slide, and why the survey was conducted in the first place. There's a lot of information out there for non-Native LGBTQ people and their experiences within the healthcare system and around either barriers to care, the treatment of care that they receive, but there's not as much information for Indigenous folks, and so really wanted to get a better understanding of people's experiences throughout the U.S. Around their healthcare access and experiences within the system. And just a note that gender diversity within Indigenous communities and sexual identity was historically celebrated and revered, but the colonization of Indigenous peoples in the U.S. resulted in forced assimilation to settler beliefs and practices. So a lot of folks that may have had been Two-Spirit or trans or things like that held, prominent roles within their societies and in their Indigenous communities, but because of colonization, that was kind of pushed, and seen as, something that people should be ashamed of. And so this is why we see some of these issues around health inequities we see today. Next slide, please. So some of the methods that about the survey itself, the inclusion criteria was any person under that was 15 years of age or older that identified as American Indian or Alaska Native and were either identified as Two-Spirit or within the LGBTQ plus population or community. And they needed to reside, as I mentioned, in the United States. The participants responded to an online survey that covered a myriad of health-related and Indigenous pride topics. So the survey was quite long. I think it had about 189 pieces to it. And it was part of a larger survey, but we focused specifically on healthcare access in the 10 question scale, which I'll get to in a little bit. There's a lot of community input for the survey design, especially for some of the scales that were used within the survey, because a lot of those scales were used in non-native areas. And so in order to make it more appropriate for the population that we were really trying to target, there's a lot of community input and adjustments to be made for that. And then, of course, participants received $100 for their time and their knowledge shared with the survey team. Next slide, please. So we used the information collected on all the participants and calculated descriptive statistics on survey participants. We used a Pearson chi-square test of independence to look at those differences and comparison between gender diverse and cisgender folks within the participation group. And we analyzed, as I mentioned, responses to a 10-question scale on lived experiences to seeking and accessing healthcare. And we used ordinal logistic regression to look at the results of those on that scale. We compared cisgender and gender diverse participants to better understand potential differences in experiences. And we controlled for annual household income due to observed differences between comparison groups, which I'll show in a couple slides. Next slide, please. So in the results, we ended up with 223 completed surveys. 113 of those participants indicated or self-identified as cisgender, and 110 of them self-identified as gender diverse. We did have a total of 549 survey responses, but there was a hack during when the survey opened. And so the survey team, Itai and Morgan, they really worked through and looked through all of the individual responses to determine which ones were actually deemed actual responses versus bots or what we call fraudulent responses. The majority of the participants were from the Northwest, West, and Midwest, although we had a little bit of representation from all over the United States, and all in a very diverse group of gender identities as well as sexual identities and orientations. Next slide, please. Thank you. So as you can see here, and I know it's a little small, participants were generally younger, had at least some college or associate's degree, and they were employed. And the average age of participants was 26 with a mode of 21. And most participants lived in urban settings and had health care. So the only major difference, as I mentioned before, between the two comparison groups was annual income, and with more than half of cisgender participants making at least 20K per year, compared to the nearly 70% of gender diverse participants making less than 20K per year. And this finding was the only finding within the descriptive statistics that we found were statistically significant, and we controlled for this indicator in our logistic regression analysis model. Next slide, please. So as you can see here, which is kind of hard, I know on the small screen, but all of the dark blue lines is where there is a significant or extreme problem identified by the respondents or the participants in the survey. So these are each of the questions that we asked on the 10-question scale. In finances, lack of psychologists and other mental health support groups for Two-Spirit and LGBTQ plus communities were the top 3 experience barriers to quality care for both groups, with personal finances being the top barrier for both groups. And as you can see indicated by the little stars next to the majority of the questions here, gender diverse participants were more likely, statistically significantly more likely to respond that these were barriers for them. So they, while 71% of all participants reported a lack of adequately trained healthcare professionals in Two-Spirit and LGBTQ plus care is a barrier, gender diverse participants were significantly more likely to have experienced this barrier than their cisgender peers. So really showing that there's some disconnect between healthcare, especially for gender diverse people. Next slide, please. So these are some of the quotes in the qualitative part. Participants could enter in their thoughts about their quality of care, how they wanted to. And so you'll see some of these here stated here. I've had non-native providers for the most part, and although they may be used to working with natives, they can't determine whether they truly can grasp the experience of a native who identifies as LGBTQ plus and or two-spirit. And so these are really helpful in our, report and sharing these findings with folks on these experiences for these participants. And the findings illustrate challenges associated with the healthcare system for American Indian, Alaska Native, Two-Spirit, LGBTQ people, and particularly obtaining quality care that fulfills the healthcare needs of these communities. For instance, there's finances were a huge, the most commonly said barrier within this group. And while many of them had insurance, it was very insurance can be a barrier as well, because some folks, are bound within what the insurance companies can provide for their care. So sometimes gender affirming care is not covered by insurance. And so these are real challenges that our participants have faced. Next slide, please. So it's just some limitations. The sample does bias towards younger and more tech-savvy participants because they are younger using the internet, and it is a small sample size. I know we did want to get a larger sample size, but because of the hack, we had to end the sample or the survey shorter than what we anticipated. And so it may not be generalizable to a larger AIN population, but because of the findings, we think that it would be worthwhile to have a similar survey process be done again. Next slide, please. So some key takeaways, there's more work to be done to include and support AIN Two-Spirit LGBTQ people in the healthcare system, particularly for those who identify as gender diverse. And it's really important to incorporate Indigenous ways of knowing into Western clinical care, because it can greatly impact mental health and well-being for American Indian, Alaska Native folks seeking and receiving medical care. For example, better and more comprehensive cultural training for clinicians working with American Indian, Alaska Native populations. Many don't receive enough training, even though they are serving these populations within, reservation areas or IHS clinics and things like that. And then also increased mental health support that considers the impact of colonization of American Indian, Alaska Native, Two-Spirit, LGBTQ plus communities. Next slide, please. So you'd just like to thank, of course, acknowledge the American Indian, Alaska Native, Two-Spirit, and LGBTQ plus community, as well as the Alaska Native Tribal Health Consortium, which a lot of the work was already, they had the foundation laid for this work. And of course, who's not on here, and as I mentioned, the incredible work of my co-authors, especially, Itai, Morgan, and Jessica Leston, all the incredible work that they've been doing. Without them, this paper wouldn't have been possible. Thank you. So now I'd like to pass it over to Carolyn.
Hi, thank you so much, Ashley, and hello to everyone else on the call. My name is Carolyn Parshell. Again, I'm an epidemiologist and the Student Development Director at the Albuquerque Area Southwest Tribal Epidemiology Center, which we refer to as ASPPH for short. Thank you so much for having me to speak to our article that was submitted as part of this supplement. I'd like to start out by acknowledging my co-authors, Dr. Faris Kadan, Judith Espinosa, and Dr. Kevin English. So we are all part of the Aztec team, which is housed within the Albuquerque Area Indian Health Board, and we serve the 27 tribal communities in New Mexico, Southern Colorado, Southeast Utah, and the El Paso area of Texas. Next slide, please. So the purpose of the work that is documented in our manuscript is to really address the data disparity issue where AIAN pupils are often not adequately or appropriately represented in much of the current data. So, you know, a lot of times at the county and even at state level reporting, the AIAN category you know, is comprised of such a small sample that, you know, it doesn't really feel like an accurate representation. On the other hand, the AIAN category often gets, you know, completely suppressed due to small numbers, or it gets combined with other racial ethnic groups. And so, you know, all of this leads or can lead to an overall kind of inability to accurately quantify and understand health behaviors of AIAN populations. And so our article really focuses in on a method that we used to adapt an existing statewide surveillance system to benefit and better serve the needs of AIAN peoples and the tribal communities that we serve in New Mexico. Next slide, please. So some of you may be familiar with the CDC's Youth Risk Behavior Surveillance System, which is an anonymous voluntary survey that captures data related to health behaviors, conditions, and experiences of students in grades 6 through 12. And so the New Mexico Department of Health has been administering a state-specific version of the survey for many years, and that's called the New Mexico Youth Risk and Resiliency Survey, or the NMYRS. And so under the normal NMYRS sampling framework, schools in the state are selected to administer the survey, and then the probability of a school being chosen is proportional to the size of the school based on their student enrollment. And so, you know, then at each school that is identified to take part in the survey, a random sample of classrooms is chosen to actually administer it. So under this sampling framework, smaller, more rural schools in the state, often, you know, the ones that are serving students from tribal communities, they don't get chosen to administer the NMYRS. And so this kind of created a situation where, you know, there just wasn't adequate representation of AIAN youth in the overall NMYRS state data. And then the numbers were just too small to even be included in a lot of the county level reporting. And so to address this, in 2007, Aztec, in consultation with tribal leadership, formed a partnership with the New Mexico Department of Health, the New Mexico Public Education Department, and the University of New Mexico to incorporate an AIAN oversample component into the existing NMYRS protocol. Next slide, please. So as part of this oversample project, Aztec worked with tribal leaders to identify specific schools that were serving youth from their tribal communities to administer the NMYRS. And so instead of only a small sample of students from each school completing the survey, the NMYRS was administered to every student at these schools. And so this project started with a pilot in 2007, where the survey was administered to 100% of students from 3 schools located in tribal communities. And so from this pilot, we saw a 70% response rate. And each subsequent survey cycle, we would work with tribal leadership to increase the number of schools in our oversample framework to where now, you know, we invite all schools located on or adjacent to tribal communities to participate in the NMYRS. We also invite schools with a high percentage of AIAN students enrolled. to participate in the oversample framework. And this year for the 2023 NMYRS, we have 20 high schools and 28 middle schools participating in the NMYRS AIN oversample framework. And so using this oversample method, we are usually able to administer the NMYRS to an additional 3,500 AIAN students throughout the state, which results in, you know, a nice, robust, and what we believe to be a more representative state data set that allows for more complex analyses of students who identify as AIAN. And so to demonstrate the utility of these data, we did include in our manuscript an analysis looking at the protective effect of several variables against suicide indicators among AIAN youth, stratified by sex. And we found that among AIAN middle school females, community connectedness and family support were associated with significantly decreased odds of having thought about suicide, having made a suicide plan, and having ever attempted suicide. Among male AIAN middle school students, we found school support to be the most protective against these same 3 suicide-related outcome measures. And so being able to perform these more complex analyses to produce reliable results is definitely a benefit of this robust data set that's produced through the AIAN oversample project. But maybe even, you know, more meaningful is that we're able to analyze data at a more granular level, which is really useful for schools and tribal communities. And so following each survey cycle, we produce school-specific data reports for each of the schools that administer the NMYRS in our oversample framework. And this is versus schools that are not in the oversample framework. They only receive data reports at the county level. Excuse me. So being able to kind of get this look at the health behaviors of their student population specifically is very useful and meaningful to school administration and tribal partners. And then, you know, they often use their NMYRS data in grant writing, program planning activities, and tracking trends in the health behaviors of their youth. So in addition to providing these standard school-specific reports, ASTEC also provides ongoing technical assistance to schools and tribal communities who have questions or want to do more in-depth data analyses. And we also regularly hold data presentations for school administration and teachers who maybe just want to better understand their students' data. And so these school-specific data are not publicly available. They are considered the property of each school and each tribal community. And so, you know, we really want to recognize that AIAN data at the granular level needs to be protected. So while ASTEC houses the NMYRS data, we do not release it without written permission from, you know, a school or tribal leadership. Next slide, please. So I know I really kind of glossed over the analysis part of our article, but I did, you know, want to use this time to highlight the approach that our epicenter has taken to adapt the sampling method of this existing surveillance tool to be able to better understand and meet the needs of AIAN youth in our state. And so this was really only possible, this work is only possible through partnership and collaboration with our state and academic partners, and of course through the consultation and guidance of tribal leadership. And so there's many folks to thank here, you know, again, my co-authors and other ASTEC staff who work on and support this project. Of course, our program partners who make this collaborative effort possible. And then, of course, school administrators and teachers who work on the survey, tribal partners and leadership who advocate for the survey. And then, of course, you know, the students who actually complete the survey. I also want to thank Kristen Mitchell and Alaska Native Epicenter for taking the lead on the supplement endeavor. And then, of course, Public Health Reports and ASPPH for amplifying the work that TECs are doing and for hosting us here today. So with that, I'm going to go ahead and pass it over to Kristen.
Hi, everyone, and thanks for attending our webinar today. I'm really excited to be here with the authors of the journal supplement. We're now ready to take questions from the audience, so feel free to type them in the Q&A. And we also have some other questions that I'm going to pose to our authors in the meantime. If you want to craft your own, feel free to throw that in there. And I'm going to also throw some out to our authors as well. And the first one I'm going to pose to Megan, and it's twofold. If you could tell us why the TECs currently do not have access to PHI as required by law, and then what needs to be done to get to improve TEC access to PHI.
Great question, because it's something I get asked a lot. I think the why is multifactorial, and I probably don't know all the reasons, but some of them that were pointed out by the GAO report have to do with a lack of policies within HHS that kind of lay out that TECs are supposed to have access to that data and how it should be given. Why aren't they in place? I'm not sure. I think other reasons TECs and tribes, for that matter, struggle to get access to data have to do with the way that the public health data system is structured. That this data flows often from clinics to say a state health department and up to the federal government, and those systems were built without tribes or TECs ever kind of having a formal place. And so now that they're in place, what we're trying to do is figure out how we can access those data streams. What needs to be done, again, I'll just refer to the GAO report, which did give recommendations, including asking that HHS develop a policy that outlines how this information should be given and what should be given. To be clear, the statute I shared with you is pretty clear. It's pretty much anything we want is what should be given and what's needed. I guess I should say there's not really a limit placed on it as long as it's held within HHS, and making sure that all the agencies have a pathway for TECs to request the data and receive it in a timely manner. Because data is necessary, of course, to do public health, but really what we're talking about is saving people's lives. That's really what it comes down to. You need access to data. It needs to be timely. You need what you need when you need it. And so working out those processes, especially at the federal level, are really important so that we can work on keeping people healthy and addressing health disparities in Indian country.
Great, thanks, Megan. And Megan has referred to the GAO report several times, so I'm just going to go ahead and post a link to that report. It is publicly free, available on the GAO website, and I just posted a link to that in the chat if anybody's curious to read the entire report. It was actually very well done and a great summary. And we do have a question in our question and answer section for Carolyn. Could you please describe again the two-stage sampling method you used for the New Mexico study?
Hi, yes, thank you very much for that question. So the state actually uses the two-stage sampling method. And so it's a classroom level sampling method. So schools within New Mexico are chosen to participate in the survey based on their odds of being chosen are proportional to their size based on student enrollment. So, you know, the bigger schools are more likely to get chosen to participate. And then once a school is chosen, certain classrooms within that school are then chosen to actually administer the survey. And so the approach that we take in our oversample framework is much more straightforward. You know, the schools just need to meet a couple of criteria. So they need to be located either on or nearby a tribal community, or they need to enroll a high percentage of AIAN students. And so if those criteria are met, we then approach the school, we offer them the opportunity to administer the survey to 100% of their students. And so that's the approach that we've taken with the oversample framework.
Great. Thanks, Carolyn. I hope that answered our posed question. And this question is also provided by our audience for Ashley and Itai. Does the Two-Spirit article include results on the pride and connectedness measures? And this person would love to see the results.
Yeah, thanks so much for that question. I think, we went back and forth on how to include it into the analysis. I believe there is some discussion in the paper itself, in the manuscript itself, about the fact that the majority of participants felt very strongly about their indigeneity and their Indigenous identity. But we had trouble including it into the analysis in terms of having a comparison group in that sense of who didn't feel very connected. But so we have a small section, I think, in just the description in the manuscript, but I don't know if Itai wants to discuss it in ways in which they've been trying to incorporate it in other either articles or manuscripts.
Yeah, thanks for that, Ashley, and thanks for the question. One of the things that we were able to observe was we asked about pride and just identities separated from indigeneity, asking about gender identity and asking about sexual orientation. And then we asked questions about pride in indigeneity. And we saw people have expressed near total association with strong levels of pride with their indigeneity, as opposed to around the 50% mark expressing pride in gender identity and sexual orientation. And we found it was not because they did not care about sexual orientation and gender identity, but when we actually did a qualitative follow-up with these people and were able to do we did a subsample after the fact, we learned a little bit more about that. And it is that for most people in the sample, sexual orientation and gender identity are experienced as an extension of indigeneity. So it has no meaning outside of the context of being Indigenous. And so that was really important. We actually have a manuscript in review currently where we're exploring more about that.
Well, thank you both. I have another question. No others from the audience, so I have another question. This one I'm going to back to Megan. We'll just do a round robin. What are the consequences of TECs not having access to PHI as required by law?
Yeah, I think that during the pandemic, we all became more aware of the consequences of not having access to information, health information, and what they could be. I'm trained as an epidemiologist, so I like data and I need it to do epi, but not everybody is. But during the pandemic, we found out how much you need real-time data, right? You need to know who's sick so that you can help them in whatever they need, right? Tribes were trying to provide wraparound services, give places for people to stay, quarantine them. If it's a different disease, there might be treatments you can give, all sorts of services that you can provide, let alone monitoring the rates of the disease in the community, make informed decisions for the public in terms of what kind of interventions, measure your interventions. I mean, you really can't do public health without data. And so without it, you're limited in what you can do, you're limited in your responses. And I do believe that this hindrance for Indian country in receiving public health data significantly contributes to the health disparities that Native people face. And if we can improve the sharing and access of information, tribes can take more control over their public health activities and do more, and that will help improve the health of communities.
Great, thanks, Megan. Carolyn, one more for you. How does Aztec work with the state and academic partners to support the continuation of the NMYRRS, American Indian Alaska Native Oversample Project?
Yeah, thank you, Kristen. So the NMYRS project is, technically led by our state Department of Health and the University of New Mexico, but Aztec holds a seat on the steering committee, and we are, pretty much involved in all aspects of the project. So we do lead recruitment efforts for the schools in the AIAN oversample. We work directly with the school administration and staff to coordinate the actual administration of the survey every other year. We provide thank you gifts to all the teachers, all the schools that participate in our oversample. We work with the DOH and the university to do regional data reporting, and we participate in the ongoing kind of review of the survey instrument. And so, after every survey cycle, the steering committee works together to identify questions on the instrument that should, either be taken out or updated. And then we also propose new questions to be added to the survey instrument. Thank you.
Great, thanks, Carolyn. And one more for Ashley and Itai. What are some ways clinicians can support quality care for American Indian and Alaska Native patients that identify as Two-Spirit and or are part of the LGBTQ community?
I thank you for this. I would really love to offer first an invite to look up our Indian Country Echo that is for trans and gender affirming care for clinicians. We also have a warm line that's offered through the board, and all that information can be accessed at pathsremembered.org. We can put that in the chat as well. So that clinical warm line is to get advice and recommendations on specific cases as it relates to meeting the needs of 2S LGBTQ plus people. We additionally want to put some emphasis on the importance of having people self-defined, what their gender difference and diversity means to them, and to not make assumptions based on best practices in Western medicine, which oftentimes assumes things like binaries or assumes that gender dysphoria is intrinsic versus something that is extrinsic or created by society. And so there's a lot of biases built into that medical system, but we're able to offer a lot more specifics with that in the ECHO and in our strategic plan, which I can also provide a link to. The strategic plan is a guideline for implementation of gender affirming care in Indigenous settings. So I'm going to blast resources at you for just a moment via the chat. Thank you for the question.
And I added some in as you were talking. I went online and got those links for you. And now I have one last question, and this can be to anyone on our panel today. From your perspective, what do you think is the most important contribution TECs make to the tribal public health system? And this can be anyone.
Well, I guess I'll try. I'll take a stab. I can't speak for all TECs. I know people at all the TECs, and I think we all do great work, but I can only speak for our TEC. We are housed under the health board, so my bosses are the tribal leaders in our area, all of them. So I feel like we support whatever they need support on as it relates to public health. So I think of us as kind of an extension for things that they might need, expertise, skills that they might not have in their community yet, because everybody's different, and that we can provide that and help them move in the direction they want to go with their public health services, ultimately for the common goal of improving the health of Native people in our area.
Great, thanks, Megan. Ashley?
Yeah, I just want to echo what Megan said. I think I think we have a really great opportunity to support the tribes from the TEC, and we're also the Northwest Portland Area Indian Health Board the TEC is also under the health board there. I think it's also the TEC provides a really great opportunity to provide policy support as well to tribes, both as a collective and individually. And I think it's an invaluable tool that we can provide because policy changes and affects so much, as Megan's presentation was very clear on. And, I think there's challenges there, but the TECs can provide that support and keep pushing on behalf of the tribes to affect change.
Great. Thank you, Ashley. Carolyn?
Yeah, I think I'm just gonna kind of echo a lot of what's already been mentioned, and this may be more of my personal opinion, but I feel like as a TEC, we're kind of able to maybe work outside a lot of the constraints that maybe come with like operating within the state or federal government. And so I feel like this gives us kind of the flexibility and freedom to meet tribal communities where they're at, and to ensure that, all of our work is being informed and driven by the communities and by tribal leadership. And I think that allows us to form stronger relationships and to work in a way that is, meaningful and respectful and sustainable.
Thanks, Carolyn. Itayi, did you have any part of the last words? No. Okay. Well, we have about 5 minutes left of our webinar time today, and that's all my questions for the panelists, unless anybody else in the group has a question for our fantastic TEC authors. And with that, I'll pass it back to Dr. Dean.
Thank you for joining us today. You may access the full special issue at the Public Health Reports website listed here on this slide. A special thank you to the speakers and their staff for their time and contributions addressing the major health challenges facing the United States today and the work of Tribal Epidemiology Centers. I also want to thank the Association of Schools and Programs of Public Health, ASPPH, and the Office of the U.S. Surgeon General for their continuous support of public health reports. As a reminder, this webinar will be archived on the ASPPH YouTube channel for future viewing. This is the end of the ASPPH Presents Public Health Reports Meet the Author webinar. Thank you and have a very good day.